is going to be telling us about the ARPA-H program in this Founders Day that's going to be happening in May. And it's my pleasure to introduce today's speaker, Dr. Jonathan Perkins. He's a professor in Pediatric Otolaryngology and head and neck surgery at Seattle Children's Hospital. And today, he's going to tell us about lymphatic malformations, and the title of his presentation is A Tale of Two, actually three, lymphatic malformations. And this is going to summarize how treatment has changed over the past 25 years based on genetics. So with that, I'll turn it over to Jonathan.
Hi, thanks for the invite. Can you see the right screen, the correct presentation screen?
Yes.
Perfect. So, I hope, thanks for the invite. I hope what I have to share is of value to you all, and we'll get on with it. So I'd like to tell you about actually three lymphatic malformations and how their treatment is different. I have no conflicts of interest and no disclosures. Today, my objectives are threefold. First, to discuss changes in head and neck lymphatic malformation evaluation over the past 25 years. Second, to describe current medical genetics and biology of lymphatic malformations. And third, to explain how this has resulted in new treatment strategies for head and neck lymphatic malformations. I was inspired by the Charles Dickens classic, The Tale of Two Cities, by his first sentence in the book. It was the best of times, it was the worst of times, it was the age of wisdom, it was the age of foolishness, it was the epoch of belief, it was the epoch of incredulity. I think we are in an unbelievable epoch of lymphatic malformation assessment and treatment that I will try to explain in this talk. For those of you who don't know what incredulity means, it means disbelief or unwillingness to believe. We don't use that word much today. If someone would have told me 20 years ago we could treat vascular anomalies with medicine, I would have laughed at them. Over the past 30 years, there have been conflicting ideas about lymphatic malformation treatment. Joe Gruss, one of my former colleagues, said, Jonathan, head and neck lymphatic malformations are not a surgical disease. Richard Smith, a prominent otolaryngologist at the University of Iowa, said sclerotherapy is the new treatment for lymphatic malformations. Neither of these ideas completely capture lymphatic malformation treatment challenges. Over the past 20 years, at Children's, we have been actively trying to understand lymphatic malformations from different vantage points. In this talk, I will describe these patients' experiences. They were born approximately 10 years apart between 2000 and 2019. These patients have lymphatic malformations of similar size and distribution. Since 2000, our understanding of lymphatic malformations' natural history, treatment responsiveness, and molecular biology have changed. Changing knowledge has resulted in treatment change. These patients' treatment experience has been very different. We will focus on how and why these outcomes have been different or the same in some cases. In 2014, we published a paper examining the efficacy of surgery versus sclerotherapy for head and neck lymphatic malformations. In our study, we combined patients from UC San Diego and Seattle Children's and categorized each patient into a lymphatic malformation stage. This figure from the paper shows that 85% of lymphatic malformations were unilateral and stages 1 to 3. Stage 4 and 5 represented only 15% of all head and neck lymphatic malformations. The three patients in this talk have stage 5 head and neck lymphatic malformations. When examining the natural history of head and neck lymphatic malformations, it has become obvious that stage 1 to 3 malformations do not have significant functional compromise in breathing or eating. For this reason, I am now lumping them together as grade 1. In contrast, stage 4 and 5 malformations usually have significant problems with breathing and feeding, and I've designated them grade 2. Through this work, it has become obvious that the natural history of grade 1 head and neck lymphatic malformations are very different from grade 2. In fact, when possible, delaying invasive therapy in all lymphatic malformations improves functional treatment outcomes, especially for grade 2 malformations. Head and neck lymphatic malformations are usually diagnosed in utero with ultrasound. When grade 2 head and neck lymphatic malformations are seen, further evaluation with in utero MRI scans and maternal fetal medicine evaluation is necessary to determine a delivery plan. Prenatal delivery planning is important to reduce postnatal risk for both the fetus and the mother. In patient 1, a C-section was performed without any adjunctive measures for airway support and resuscitation. We were lucky that this patient did not have airway loss at delivery. After 2000, the exit procedure became more popular, and at Seattle Children's, a prenatal clinic was formed through collaboration with the UW, University of Washington Maternal Fetal Medicine Service. Patients 2 and 3 were born via exit procedure. During an exit procedure, maternal fetal circulation is maintained to support the baby during the C-section. At delivery, the baby's airway is secured through endotracheal intubation. Once this is completed, the rest of the delivery takes place in a more routine fashion. Performing an exit procedure involves many people. This is a schematic diagram created by Eden Palmer. It describes how we position providers in the delivery room. Different groups collaborate in this procedure, including OB anesthesia for the mother, maternal fetal medicine, neonatology, pediatric anesthesia, and pediatric otolaryngology. We still use this diagram to help us plan the logistics of exit procedures so that everybody has a place to stand and work. Depending on the location of the malformation, often other medical and surgical services are involved. We now perform these procedures in a main operating room at the University of Washington. This gives us more room to work and helps communication immensely before, after, and during the procedure. These are photos from an exit procedure in a patient with a lymphatic malformation. Notice how the endotracheal tube is in place and pediatric anesthesia is carefully transporting the patient from the delivery table to waiting neonatologist. With experience, we have realized that not all patients need an exit procedure. We now reserve this procedure for pregnancies complicated by polyhydramnios, MRI evidence of poor fetal swallowing, and a fetal age of over 34 weeks gestation, or 34 weeks. We work together with the family and involved providers to optimize care and safety. After the baby is born and stabilized, a postnatal assessment is performed to set treatment goals. If there is functional compromise in the airway and feeding, these are addressed primarily. In this situation, primary goals are extubation and normal oral feeding. The assessment is usually done with head and neck MRI and airway endoscopy. In patient 1, a CT scan demonstrated an extensive lymphatic malformation that completely displaced his airway to the right neck. So this is the airway here. It should be over here somewhere. Sclerotherapy reduced the size of the large cysts in the malformation, but not completely. This is shown in the middle radiographic photo and clinical photos here. After sclerotherapy, the trachea was still deviated maximally to the right side. And we had to place a trach in the right side of the neck to obtain an airway. This patient had multiple airway endoscopies, and still has an indwelling tracheotomy. I believe this trip to swim with the dolphin was funded through the Make-A-Wish Foundation. They didn't consult with us about a trach and swimming. Usually we don't recommend swimming with the trach tube. Initial postnatal assessment, as I learned more about imaging sensitivity, we switched from CT scans to MRI for postnatal assessment. The MRI demonstrates fluid-filled spaces and vascularity very effectively, such that we can determine the composition of a given malformation. In patients 2 and 3, both had extensive, large, non-enhancing fluid-filled spaces consistent with lymphatic malformations. Patient 2 had repeated sclerotherapy sessions over the span of 2 months, but still had an unstable airway and was unable to feed orally. The malformation was reduced in size, but not by a significant amount. At 2.5 months of age, surgical excision was performed in order to place a tracheotomy in G2. The surgery was quite extensive, involving a unilateral neck dissection, parotidectomy, and floor of mouth dissection. The purple marks on the skin are facial nerve mapping, and you can see the facial nerve identified at the blue arrow after much dissection. Facial nerve mapping is a technique we have developed at Children's in conjunction with the neuromonitoring service to preoperatively identify the facial nerve in and around vascular anomalies. We have demonstrated that this reduces surgical time while preserving facial nerve function. Patient 2 had a subsequent left neck dissection and was able to be decannulated by age 4. His G-tube was also removed at the same time. Note how his chin is very prominent. In studying mandibular growth and lymphatic malformations with an orthodontist, Dr. Barbara Scheller, and one of my colleagues, Dr. Benicia Velez, we have discovered significant anterior mandibular overgrowth compared to other parts of the mandible in patients with lymphatic malformation. To understand the cause of lymphatic malformations, I saved malformation tissue and fluid for 20 years. This provided the raw material to examine the molecular genetics of head and neck lymphatic malformations. To discover a gene that caused lymphatic malformations, we collaborated with the late Debbie Nickerson in genome medicine at the University of Washington. Andrew Kirsch, not pictured, and Mark Majeski on the left began this work with me. Bill Dobbins in the center had recently discovered the PIK3CA gene, that the PIK3CA gene causes Clove syndrome, which also has lymphatic abnormalities. He wanted to study our lymphatic malformation tissue to see if it contained PIK3CA mutations. At the time, Jimmy Bennett on the right was his postdoc trainee, and we have been working together since that time. We thought that lymphatic malformations occurred in a mosaic distribution and could be due to genetic mosaicism. Mosaicism occurs after the zygote is formed on the left. In early cell division, genetic change, possibly random, can occur in individual cells that then perpetuate this change through further cell division into the fully developed organism. These changes are shown in pink. This can lead to changes in specific parts of the body, such as macrodactyly. We then hypothesized that genetic variation present in lesional tissue could lead to malformation development. Subsequently, we have identified activated somatic gene variants in malformation tissue. Cell-free DNA in malformation cyst fluid contains genetic variants identical to malformation tissue. Using biorepository samples, we have discovered PIK3CA variants in many lymphatic malformations in the head and neck and elsewhere in the body. We also have discovered BRAF mutations in a few of these malformations. Patient A in this figure has a BRAF mutation in the neck malformation. The presence of somatic gene mutations in malformation tissue explains why malformations persist and have tissue overgrowth, making them difficult to treat. These same activated gene mutations are present in solid cancers. Drugs for cancer treatment have been developed to prevent activation of these genes. These same medications are being used for lymphatic malformation treatment. We have been using this targeted therapy for the past 10 years at Seattle Children's. Activated PIK3CA variants or mutations cause tissue overgrowth and decreased cell death, commonly seen in vascular malformations. We have only detected PIK3CA hotspot variants in lymphatic malformations. We are able to detect these variations in our research lab as well as the clinical lab. Dr. Bennett has developed two clinical assays, the Van-Seek panel and the SpotSeq targeted digital droplet assay for clinical testing for genetic variants in malformations. The digital droplet PCR assay only looks at 6 different loci and genes commonly mutated in vascular anomalies. This diagram demonstrates the Pi3K pathway, which is activated by a catalyst protein formed by PIK3CA right here. This pathway can be inhibited by several different medications, including aspirin, sirolimus, an AKT inhibitor, moransertib, and a PIK3CA inhibitor, alpelisib. We have been using sirolimus, aspirin, and alpelisib frequently for these conditions. There are ongoing drug trials for both alpelisib and moransertib at Seattle Children's. Patient 3 underwent an exit procedure and had a genetic diagnosis using cell-free DNA from a lymphatic malformation cyst. He has only been treated with sirolimus and alpelisib. Sirolimus was begun at birth, and then at age 2, we switched him to alpelisib. You can see the outcome at 5 years of age. His mandible and lower face are enlarged. His parents note that when playing at the playground, he is asked by his peers why his head is big. He had a G-tube for a few years, and this is no longer present. He sleeps well and does not snore. These are MRI changes seen with targeted medical therapy in patient 3. The large cyst completely resolved, but there is increased fluid signal in the region of the malformation. We are currently studying the longitudinal medicine effects on lymphatic malformation composition using MRI. Here we see a summary of the 3 different patients' clinical experiences. All these patients had grade 2 lymphatic malformations and had the same genotype, PIK3CA E545K, one of the hotspots in that gene. Patient 1 had a very lengthy hospital course, primarily in the ICU. He was in the hospital for almost 2 years, had over 27 procedures, and expended 2 health insurance policies. He has an indwelling trach because of iatrogenic laryngeal stenosis and vocal cord paralysis. Archived malformation tissue was used to make his genotypic diagnosis. During the first several years of his life, he almost died on multiple occasions. His primary source of morbidity was massive chest chyluria. Note his facial asymmetry at age 20. Patient 2 was in the hospital for 12 months in the first 5 years of his life. He had 17 procedures, including a tracheotomy and a G-tube. By age 4, we had removed both these devices. His genetic diagnosis was obtained through fresh frozen tissue with both exome sequencing and targeted PIK3CA sequencing. He probably still has some elements of sleep apnea and pain with malformation trauma. Patient 3 has not had any surgery except for airway endoscopy and a G-tube. He spent only 2 months in the hospital prior to being discharged. He has never required readmission to the hospital for illness or following any procedures. He has never had a tracheotomy and is able to play and perform normal activities without malformation symptoms, which is highly uncommon. Patient 3 has only been treated medically. You can see that his mandible is enlarged and there is some evidence for overgrowth of his facial skeleton and cranium. To improve the treatment outcomes of patients with rare conditions such as vascular anomalies or lymphatic malformations, alignment of conflicting treatment ideas and philosophies is essential. We have found that data gathered from a standardized assessment of vascular anomalies has allowed us to begin to address specific questions. These questions include understanding the natural history of head and neck lymphatic malformations, determining when medical or surgical therapy is best, guiding genetic testing and measurement of outcomes. These patients may all need long-term follow-up and a transition from pediatric to adult care as longevity and physical capabilities are expanded. One of the things I've been thinking about is how to apply natural history and baseline assessment data to a given patient's treatment. This patient presented with a non-tender asymptomatic grade 1 lymphatic malformation at age 4 on the right side of his neck. Nothing was done other than give a diagnosis. 5 years later, the patient had malformation enlargement and pain as would be expected. The family then decided they wanted to pursue surgical excision. This mass on MRI was well circumscribed. Surgical excision was possible because of this, and complete removal was obtained. Here are the pre and post excision MRI scans. So this is pre here with the white mass that's fluid-filled lymphatic malformation, and afterwards is over here, and you don't see that white mass. Maybe a slight bit of increased fluid signal right here. Cell-free DNA from the patient's cyst fluid was used for a PIK3CA diagnosis. The patient is now completely asymptomatic, so primary surgery is still a good option in some cases. Natural history consideration is important when superficial oral tongue lymphatic malformations. These recur after treatment. This patient had slow malformation growth over 7 years. The treatment was indicated secondary to tongue appearance, pain, and bleeding. These lesions were excised directly. Postoperative aspirin was used to improve healing and prevent malformation regrowth. Note how the tongue width was changed and there's no malformation regrowth. Pre-op, the tongue overlies the teeth, and post-op, it does not. Adjunctive suppression of the PI3K pathway is possible with aspirin and can improve the surgical outcome. Natural history of grade 2 lymphatic malformations with tracheotomy usually means a lifelong tracheotomy. Secondary appellasive therapy after distant surgical excision has resulted in decannulation of several patients with long-standing tracheotomy. Notice the airway development on this patient's sagittal MRI scan. Right here, there's no airway, and then there's an airway over here. Note the laryngeal structural changes that can be seen endoscopically. Lots of edema here with distorted anatomy, more normal anatomy over here. This patient's sleep study normalized after 18 months of appellasive therapy, and she was decannulated. In these 3 cases, data and targeted therapies have been used to successfully change the malformation natural history. Current vascular anomaly evaluation and treatment involves clinical evaluation, imaging, and selective laboratory assessment, genetic counseling, and/or evaluation, treatment planning based on functional status, and family choice. Realize that some of the targeted therapies are very expensive. Appellasive is $1,000 per pill, and 1 pill is used each day. Finally, longitudinal follow-up of these patients is essential to optimize our understanding of their condition, their health, and functional status. None of this work would have been possible without an engaged, interested team of clinicians and scientists. This is the group at Seattle Children's. I'm extremely grateful to all these people for many discussions and continued interest in this work that has been occurring for the past 25 years. This harvest painting by Peter Bruegel from the 1600s is one of my favorites. I feel like this guy in the front by the tree, just laying back and recovering from a hard day's work. Thank you. I'll welcome any questions.
Thank you, Jonathan. That was a great presentation. And I had a quick question. I was wondering if you could comment on what's driving the mandibular overgrowth in some of these patients.
Yeah, that's a good question because we don't know. Short answer, we don't know. There's been not just a few papers on bone changes with lymphatic malformations that I'm aware of in the facial skeleton. So facial bones are kind of different than long bones in the sense that they're formed differently, and neural crest cells are involved and that sort of thing. So there's a lot of unanswered questions. We are looking for, it's hard to get the bone to have to have a sample. So we just have some sample just in the last several weeks that we're looking at to see if we have can detect a PIK3CA variant in that tissue, in those cells. There's this idea about somatic mutations or variants in a given cell causing non-autonomous cell behavior around them. So, is the PIK3CA gene in all the tissues in the face, or is it just in some cells, in some of the tissues, and then those trigger this weird growth? We do know that the mandible grows in relation to the tongue. So if somebody has macroglossia, they often will have overgrowth of the mandible, even if they don't have a malformation or anything. They just have a big tongue. So we know there's physical forces that can affect the facial bones too. So it's an interesting thing, and we're interested in finding it out for sure.
Yeah, and I think it'll be interesting if over time, if we see that some of these targeted therapies targeting the PI3 kinase AKT pathway could also impact that bone hypertrophy.
Well, yeah, I'm very interested in that also. I can tell you that we have about 40 patients on alpelisib, and I have not seen any bony changes. But it's only been a couple of years, right? So we don't know the whole answer. Like maybe we're doing something that will become more apparent as the patient gets bigger and older and stuff like that.
And we have a question from the audience. It's in the chat, but I'll read it. Dr. Perkins, thank you for the great presentation. Could you comment on whether the linear growth of any of the young children were affected on long-term treatment with alpelisib or overall growth?
Yeah, I don't think we've seen that, but it's not been that long. So, and then when we start somebody when they're a teenager, for instance, we haven't seen any change. So there have been some patients where, is there a poor appetite? And those patients have all been adolescents. So it's actually kind of hard for me to figure out whether it's a behavioral thing or it's truly appetite suppression. I don't know. We're working on it. We are aware of it and we follow all those things carefully.
And there's another question. Scott has one. Scott, would you like to unmute yourself and ask your question?
Good thing. Yeah, thank you. I was just curious if these same drugs have been used for blood vascular malformations in addition to lymphatics.
So so alpelisib is specific for PIK3CA. So if somebody has a PIK3CA mutation and they have a venous malformation, we would entertain using that drug. There's other mutations, as you're probably aware of, MAP2 kinase, which causes extracranial AVMs sometimes. And there's, trametinib, there's other MEK1 inhibitors besides trametinib, but that has been used in those lesions. And I think now is like there's kind of provisional FDA approval for it too. So we've used those things. I think that, the jury is out on how to actually apply these things. I work with Dr. Ng. She's a hematologist, oncologist, and she's, an expert in these things. And she says she really likes sirolimus. Well, I know she really likes sirolimus. So we use that too. But so I hope that answers the question.
Yeah, thank you.
And Carrie, would you like to unmute yourself?
Oh, yes. I was wondering, since you have a large cohort on alpelisib, do you see issues with glucose levels? And do you also we've had some cases here at Columbia where we have to also treat them with metformin.
Yeah. Short answer is we haven't. And I think it's because we're treating kids primarily. So we haven't had any trouble with glucose metabolism at this point. I have seen it in one adult who, it's not just a lymphatic malformation that this person's being treated for. And there's other things that would predispose that person to type 2 diabetes physiology. But that person is being treated. But we haven't seen it in children, which is kind of interesting to me.
Yeah, we've seen it in teenagers mostly, so not young children.
Yeah, I would think, my opinion is, if somebody's going to be prone to type 2 diabetes, have other stigmata of that, they might very well have trouble with, hyperglycemia.
All right. And then we have one more question. This was in the chat. So thoughts about prenatal maternal sirolimus therapy to treat fetuses with large head and neck LMs.
Well, it's being done, I guess. And we've been actively discussing it. We have our maternal fetal medicine docs are very much, we work together well. There's a fetal medicine group too. So, I think we're open to it. We've been discussing, like which drugs to use, that sort of thing. And I can't say any more than that right now.
Well, thank you once again. We've had a great presentation and a really great discussion after the presentation.
I see that Dr. Tang has a question about intracranial stuff.
Okay.
Yeah, this is an interesting question. So I don't know about sirolimus. We don't know, because we don't think that sirolimus helps penetrates the blood-brain barrier. And we've worked a lot, like Dr. Dobbins, his specialty is brain dysmorphology and chronic seizures and stuff. So there's a lot of PIK3CA abnormalities in the brain. And the official word from the company Novartis was that, well, if there's a malformation that's adjacent to the brain or adjacent to the cranium, maybe it would cross the blood-brain barrier to treat something that's in the brain. And I can tell you that we have not seen that. So it's an interesting thing, and I wished it worked, but we haven't seen it.
All right.
All right.
Thank you once again. And